Hey guys, welcome to our new case presentation. Today we will compare an immediate implant placement and immediate loading with a delayed immediate implant placement with a provisional denture supply. Let's start with case 1, immediate implant placement and immediate loading. Our patient is a young woman of 24 that has been quite unhappy with her persisting canines in the upper jaw. Because of the agenesis of the permanent canines and the preceded abrasion and destruction of the milk teeth, we decided to extract the teeth and to place implants immediately. The X-ray showed a comfortable situation for immediate implant placement as the roots of the milk teeth have been short and those of the neighbor teeth haven't been converging. The only difficulty was the deep bite that impeded the provisional supply. It wouldn't have been possible to insert a denture, neither to take the former crown as provisional. The only solution that was acceptable in this aesthetic zone has been the immediate loading of the implants. That's why it has been very important to choose an implant that provides an optimal primary stability. For the cases shown in this presentation, I used MegaGen AnyRidge implants. In contrast to other implant systems, there is no decrease in implant stability after 3 to 4 weeks. Due to the stress-minimizing thread design, bone necrosis is no problem, what results in a maintaining or even increasing stability, allowing immediate implant placement, immediate loading, and the use of short implants. Because of the shortness of the roots, atraumatic extraction has been very easy in this case. Generally, it's a basic requirement wherever you are planning to insert an implant. When you are not working with a drilling template, you should verify your drill access, especially when the extracted tooth has been close to his neighbor. We use the MegaGen AnyRidge 3.5 of diameter and 11.5 of length on both sides. Whenever an implant is about to be loaded immediately, you should control the implant stability quotient. The well-known ting you hear when tapping on the cover screw with an instrument can only be a hint, and even the insertion torque can't offer you the information on the stability like the ISQ measurement does. In this case, both sides showed an ISQ of 75 and were thus ready for being loaded. Before going on, a control X-ray is, of course, indispensable. The challenge was to insert some temporary crowns within the small space we had, while avoiding any kind of strong forces on the implants. Here you see the final result just before the patients left our practice on the day of surgery. Let's have a look how I've got there. I waved the caps of the fuse abutments and reduced them until there was no more contact on them. After protecting the wound margins from resin and our working space from humidity by retracting threads, 2 new canines have been modeled. The higher the ISQ, the lower is the risk of the development of fibrous tissue and later implant loss when loading the implant. To prevent any complications, every patient should be told to avoid biting and chewing with the temporary crowns for the first weeks. As the resin had so little abutment to lean on, I decided to insert the final crowns on customized abutments at once. We inserted the scan abutments 3 days after surgery. The following slides show the scan. These are the resulting printed models, where you can see again the small space available because of the deep bite. But as an orthodontic treatment hadn't been an option for the patient, we had to be content with the space we got. This is the final result with inserted zircon crowns 1 week after surgery. Let's have a look at the second case, a delayed immediate implant placement. A 94-year-old female patient that came to our practice with a provisional denture covering the gap of the middle upper front tooth on the left side that had been extracted some weeks before after an unsuccessful apicoectomy. There has been an area of secondary healing that I avoided by a surgical cut on the palatal side of the jaw. When working guided, it's possible to only punch through the soft tissue. When I'm forced to create a flap because of the need for bone augmentation, I prefer an incision that is more oral for several reasons. You avoid sutures right above the cover screw, have more soft tissue to model the outer side of your augmentation, and the sutures are less visible. Either because of the apicoectomy or an extraction that damaged the buccal bone, there was a huge bone defect that I cleaned from granulation tissue. The sterilized floss is quite practical, not only for staying palatal with your drill, but also for holding the flap without instrument pressure on the buccal bone. As usual, I'd verified the access by X-ray. After having prepared the implant bed with extending drills, I inserted a MegaGen AnyRidge implant 3.5 by 11.5 mm. Despite the bone defect, the implant showed a very good primary stability because of the specialized thread design. After augmentation with a bovine bone substitute material, I covered the augmentation with a native collagen membrane. A mattress suture that only adapts the two small flaps takes tension from the weak spot left after extraction and the bound margins that can be fixed afterwards by simple interrupted sutures. Neither the post-op X-ray nor the clinical control the day after surgery or when removing the sutures showed any abnormalities. But 3 weeks after surgery, the patient entered the practice with this situation. A soft tissue defect in the aesthetic zone is always annoying because every attempt to cover it with a flap could lead to an aesthetically less acceptable result. Surely, there will be a lot of colleagues that will tell me the silk I was using for the sutures has been the reason for this dehiscence. But to be honest, the reason why I prefer silk is that I've got dehiscences only once or twice a year, and even if I know that a 4.0 suture is rejected by many of you, I've got very good experiences and the material is much more comfortable for the patients than monofile suture material. So what else could have been the problem? Having a look to the initial situation, there has been probably a perforation in the soft tissue where the socket hadn't been healed completely. And even if there has been space between the wound area and the prosthetic tooth, you can never exclude there has been pressure on the soft tissue. Whenever possible, try to avoid removable dentures for temporary supply. Instead of a surgical solution, I decided to treat the area with photodynamic therapy for reduction of bacteria. Additionally, the patient was instructed to rinse with an antibacterial mouthwash. Already after 2 applications, the situation had turned out much better. After 4 months, a control X-ray was made and I exposed the implant. Usually I cut out a small circle of soft tissue just above the cover screw to avoid sutures, but in this case I chose a bigger incision in order to push the soft tissue to the buccal side. ISQ measurement showed a reliable value of 77, so I inserted a healing abutment and only a few days later a scan abutment. The first crown provided by the dental technician appeared too small, so I downgraded it to a temporary crown. I recommended to reduce the lateral front tooth that was slightly broader than the one on the right side to achieve optical symmetry, and the patient agreed. The temporary crown with the narrowed lateral front tooth, and the final crown the day it was inserted. After only 1 week, we could see the papillas were developing. This has been the situation 6 weeks after insertion of the final crown. The papilla doesn't have the same length as the one on the contralateral side, but as you can see, it's growing and has already filled the black triangle that was still disturbing at the beginning. In 2005, there has been an interesting study dealing with the problem of papilla development after single implant placement. The study by Reiser showed that there is no significant difference in papilla development between immediate and delayed temporary supply. Determining for single-tooth implants has been the distance between contact point and inserted implant. Is it therefore not important if you place provisional silate? Of course, immediate implant placement is more important in the aesthetic zone to avoid loss of hard and soft tissue, but the immediate loading. But even if the riser study showed there's no significant difference, the cases I inserted temporary crowns directly after implant placement or took other action to preserve the papilla, like taking the former crown as provisional, have been much more predictable and relaxed for the patient and me than those we were forced to work with the denture. Let's have a look at the summary of 3 examples. First case again, the delayed immediate implant placement and delayed loading. Of course, not every delayed loading leads to a dehiscence. Fortunately, they are very rare, but probably it could have been avoided by a stable immediate implant without need of a removable denture. That's the situation more than half a year after surgery, but in the end, the patient is happy with the result. The second case, immediate implant placement of the right upper middle front tooth with the crown of the extracted tooth placed as temporary, is the one from part 1 of this case presentation. The final crown was inserted after 3 months. Because of a prior periodontal disease and retracted papillas before tooth extraction, the result 5 months after surgery was satisfactory. The last summarized case is the one with immediate implant placement and immediate loading. These are the final zircon crowns on customized abutments only 1 week after implant placement. Whatever the study taught us, these cases are those with an aesthetic result from the beginning and the fewest appointments in your practice what makes your patient happy. If there are any questions left, you are invited to contact me. Thank you very much for your interest in my presentation. Bye bye and stay safe.